I really like to work with those guys who are open about it. Say my least favorite person is somebody who comes in and lies. And I'm just like, it's like so frustrating to me that, like I had this dude the other day who came in and the guy's like, he's jacked. He's way bigger than me. He's got a full like facial beard and his testosterone's like, 150 or 200 and LH and FSH are suppressed. He's like reaching across his body, his triceps taking up the whole screen. And I'm like, any reason why your testosterone would be this low? No, I have no idea. Never taken anything. Nope. I'm like, it'd be better if you did, because then I would have a reason to prescribe,
All right. Hey guys, we are live here at 1D Talk. So thanks for tuning in. Got Dr. Adam Hotchkiss with us tonight. I'm excited to have him on. So TRT specialist, wife's a dietetics, all things optimal health. We're going to kind of unpack today. You may have seen him on Table Talks. I know you've been on Fuad's podcast too.
Yeah.
Which version of that was that?
Fuad's not the bro chat. Maybe one day I'll get on bro chat with that Fuad, but that'd be fun, man. But just his Real Bodybuilding podcast, I think.
That's what it was. Yeah. Justin was on that one too. And then you have your podcast, which you want to tell everybody about that?
Yeah, sure. So my podcast is the Atlas Hour. My channel is Atlas Optimization, which is the name of my wife and my company. So yeah, that one, it's kind of hard to obviously just fill in guests all the time. So I make a lot of other content on there too, just educational or some like storytelling, documentary style too, I've been playing with. So definitely trying to pump out content to some extent and hopefully podcasts here and there too.
Gotcha. And just to make us feel a little younger, we got Mr. Tanner Tattered popped in.
Sorry to interrupt you guys. Hey,
what's up, man? How's it going?
Good. Pleasure to be in your presence.
Yeah.
Well, we were just kind of doing some intros, Tanner, and I was telling Adam here about just kind of some of your content and how we've had you pop in from time to time as guest host. And for everyone out there, Justin is at North Americans, so he's got a couple clients competing. And I'm going to apologize in advance if I forget any, but I know John Rivas for super heavyweights. And then we have Selby who's competing as well. So those guys are hoping to battle for pro card. So he's been there this week. So he's not going to be with us tonight. So we wanted to tag in some extra assistance for me. So thanks for joining.
Yeah. Happy to be here.
Well, cool stuff. We'll kind of jump into it, but first, I know, so you come from a little bit different medical background, right? From ankle and foot specialist and things. Can you kind of walk through that and how you got into this more optimal living type of medicine?
Yeah. So my journey with fitness happened long before my journey with medicine. And it was kind of the impetus for my journey in medicine. So, I got into fitness and kind of got into bodybuilding, which then kind of transitioned over into like powerlifting, CrossFit for a while, but was, always active in the space. And then along with that came PEDs and a passion, I guess, for those, maybe an abuse of those for a while. And then after I was in medicine, quickly realizing that it wasn't what I thought that I was getting into. Cause I'd hoped that I'd be working with athletes and kind of, working with like-minded people. And instead, say 90 to 95% of my population was more like diabetic limb salvage, wound care, some, even reconstruction, but reconstructive because their foot is deformed due to diabetes or something. And it just wasn't, it wasn't aligned with my way of thinking. So, luckily Derek reached out to me and asked me to come on because I did have my own personal, serious passion in fitness and PED use and hormone optimization, which then transferred over into kind of longevity eventually. And right at that time too is kind of when he pulled me on. So it was kind of a merging of the two. Obviously I had the medical background and understand pharmacology, pathology, biology, and then was able to bring in all of my knowledge of PEDs and things as well.
Yeah, no, it's interesting. And I actually had a friend who worked in like the wound care. They had, now I'm going to draw a blank what the heck it's called, but he would come in and work with the docs on like the some like the compression stuff that they would get. And he's kind of told some really rough stories. I hear it's pretty gnarly with what.
Man, you can smell like the wounds, you can smell them from the waiting room, like it just stinks up an entire office, and then it's stuck in your nose for feels like days. I mean, I don't miss that smell. I'm exclusively with Merrick now, and I love it.
Well,
I
congrats
mean,
on that. Good for you.
I kind of miss the OR, occasionally, but I don't miss all of the other stuff that we did.
Got it. Well, and I think we'll kind of start to unpack it a little bit, right? Like jump it in. But I always wonder too, for physicians, like there's so much information out there online, some good, some misinformation, or maybe some partial, where people are trying to do their best to give that. Like, how do you walk that line as far as it, giving out information through content, but it's also like you're trying to walk that line with the whole medical device thing, or excuse me, medical advice piece. Like, how do you navigate that? Because I have to imagine you get a lot of questions that people are asking you to diagnose over like an instant message or something, right?
Yeah, for sure. It's tough. I mean, yeah, I don't even know how to tell people. It's like, dude, I can't, you just sent me, like a 3-sentence little thing here. I have no idea about your past medical history and everything else. I can't tell you what's going on with you. I suggest you meet me over at Merrick or something. You never want to be a dick too, because, obviously you want to help them, but it's hard.
Right.
And as far as like when it comes to content and things, I think it's pretty easy to just kind of give broad recommendations and say like, it's a good idea to keep your blood pressure low. We're not telling, this person to take 40 milligrams of telmisartan, or anything like that. Like, so the content part I feel like is pretty easy, but yeah, when people reach out in the DMs, it's always kind of tough.
Yeah. Yeah, no, I'm sure you want to try and help them with that. But I mean, Tanner, cause you've mentioned too, you get a lot of, different questions and things. I mean, what are some of the common, like, just blood work or health questions that are coming your way?
Yeah, it's one of the main points of the content that I make is that I try to make kind of helpful information accessible to people. And so I do try to answer as many DMs as I can. And that opens up a bit of a Pandora's box for people to bring questions that are really should be dedicated towards a doctor and not towards, a kid on the internet.
Yeah.
The common sorts of questions, I mean, usually it's just things floating around. How do I use this type of enhancement? How do I use this type of supplement? And at the end of the day, it's hard for people to wrap their heads around the fact that everyone's body is different. And so to approach that, either I need a lot of context from this person, and so I need to bring them into a consultation call or something to fully understand their circumstances, or to make them take a step back and realize that the dose that they're taking is going to be different than that big dude at the gym who said, oh, take this, this, and this, and you'll be huge, right?
Yeah, for sure. And then to piggyback off that too, like, you said it should be aimed towards a physician. It should be aimed towards their physician. So not just any physician they find online. Cause yeah, like when they write me, I'm like, dude, I have no idea, like I don't have your medical history to look back on or any of the pertinent things that I would need to look at. So I have no idea if you need TRT. Just throwing out like, this is the one I get all the time is like, my testosterone came back at 415, do I need testosterone? I don't know. I can't say. I can say like, generally some guys usually feel good somewhere above 600, maybe something like that, but I don't even like to give that kind of loose advice either, because it's just like, right. I have no idea about you.
Yeah, no. And so when you're kind of going through that, I mean, I think obviously there's a lot we can talk about, because it's, the clinical setting, but then, you mentioned having that PD experience beforehand. How much have you found that that's helped you through your medical career, having like the PEDs, the nutrition, the training background as you kind of went through the medical part of things?
Oh, so much, man. I mean, even in actual school before I was dealing with Merrick, where our patients obviously were very like-minded, but even in school, just having that passion, like biochemistry, when it was anything having to do with like nutrition, it was awesome, because I was like, oh, this is making sense. These are, this is what the calories are doing. And these are the carbohydrate pathways that I kind of at least know about or am excited to learn about, where there's other things, like parasites or fungus, where I'm just like, this isn't related to me in any way, so learning the biochem of that would always be difficult. So it helped a lot in that regard. And then now, I mean, having the background that I have now, I mean, like with Merrick, we deal with a lot of people who are coming in looking for like safer use protocols, or at least just some risk mitigation while they're on. And I feel like when they are able to see me across the screen and know that I'm not judging them and that I was once just like them, it's, huge.
Yeah. And just with, you just go, that's kind of thinking back to like your younger self, when you see a lot of these, patients coming in or people are asking questions, like what are some of the commonalities you see that, maybe you're like, no, don't do that. Or, just those common kind of like things that maybe aren't so
Oh,
obvious when we're younger.
everything, man. Every day I feel like such an old man, and I'm just like, oh, I know I would have hated this advice, but there's guys coming in, their blood work already looks terrible, and they're they're maybe like 25, and they're convinced that no, I'm going to be a bodybuilder, and I'm looking at them, and I'm like, I know you're not going to be a bodybuilder. Like, I don't want to be a dick, but dude, I'm looking at you, and you don't have the genetic makeup for it, and I'm trying to tell them, like. So you're 25 right now. I'm 35 right now. When I was 25, I was a completely different human being. I don't even recognize myself anymore. And you're going to be that way too. And is it worth it for you now to potentially mess up that 35-year-old who's not going to care about this, who will realize that they're not going to be an IFBB pro, So just trying to talk to people into your future self might really regret this. But then I'm torn because also I'm like, well, I did that stupid shit. I turned out okay. It was part of my journey, and I don't have any regrets per se because, it landed me where I am now. On Fuad's podcast, I was talking a lot about like, oh, I did all these PEDs. They never got me anywhere. It was stupid. I didn't become a pro. Somebody commented like, this guy keeps saying that it didn't get him anywhere, but look what his career's built him after all that use. I'm like, true. You're right. I guess I don't regret that.
Sure. Yeah. And you kind of have that first world experience. And like you said, fortunately you came out the other end and you're good from it. But Tanner, how about you? Any kind of questions that come to mind? Just, you're kind of looking to get into the bodybuilding competitive scene and working through some things, like any initial thoughts that,
yeah, no, I'll touch base. I mean, especially on just what Dr. Hotchkiss said so far, but especially within my age group, there is a really big obsession with wanting to be the youngest XYZ in whatever category. And so there are a lot of guys who are already pretty young and they're redlining their values, their blood work, and they're kind of justifying it in a way that they know that their blood work is going to be messed up, but it's a fair trade-off because I'm going to get big. But they're banking on this horizon, on this thing that's allegedly going to happen tomorrow, which still hasn't even come to fruition yet. And at least if I see people in that situation doing everything they can to mitigate side effects, to bring blood work into range if they can, then I'm a little bit more inclined to allow them some wiggle room there. But if all of those, interventions are in there and blood work is still totally out of range, there's not really much you can do. If physique is not on par with what you're taking, diet, nutrition, everything's dialed in, then it's just like what you're saying, it's a genetic issue. That is a big dynamic, especially with younger guys, because the mental shift is a lot different than it used to be, 10, 20 years ago. There's a constant bombardment of social media information, the kinds of physiques that you see other people posting. I'm this many years old and I'm like 220 pounds lean and whatever. That really gets to other kids' heads. And then they're almost incentivized to, well, dang, I want to look like him. Do I have to take this, and this, and whatever else? It's a slippery slope. It's a really dangerous landscape.
And something that I deal with a lot is that unfortunately, these days I joked on the previous podcast with Justin that TRT is now like what Cell Tech was when I was coming up.
Right.
So, it was like Cell Tech was just like slang for steroids. And now TRT is that. And, you have these influencers, like you said, 20-year-old guy who's like 240 shredded. And he's like, I'm just on TRT with XYZ clinic. That's all I'm doing. Right. And so, 17, 18-year-old kids are like, well, he's on TRT and TRT's safe. And I need to get on TRT to do that. And then they do start like testosterone and maybe they start like 200 milligrams a week or something. I'm like, great. Now you've just suppressed your endogenous production. You're probably hitting the same levels that you were naturally. And, now you're stuck potentially for life. Hopefully we catch them sooner that they're not, but that's a big deal now too, is that everybody's saying that they're on TRT when I'm like, you're not on TRT. I mean, even these clinics half the time are prescribing way more than TRT. Right. I get guys in from other clinics who are like, oh, they've got me on 400 milligrams of testosterone, like 50 Anavar, 4 IUs of GH. I'm like, you're on a full blown cycle. Like, tell me again where Anavar is endogenously produced, please.
It's interesting you say that because I'm going to date myself, but I can remember when 250 milligrams was a cycle. Like if you were a state level bodybuilder and you were over 500 milligrams, like it was like, what are you doing? Like you're not if you have to take more than that, you're not going anywhere with your career. Like, I know it's not the case now. Like, I get it. I
Right.
get it. I'm an old man. I get it. But it was just like, you know, just some of the access now and all the different compounds. But going back to the clinics, you know, you're right. It is pretty scary out there. You know, I'm sure there's some that have the best of intentions, but also I think there's others where it's, you know, I've heard people refer to it like a testosterone mill, where it's like they just come in and it's like, here's your packet and here you go. And then I'm like, well, what do they test? And it's just the most minimal testing and there's no follow-up testing. And, you know, can you kind of walk through like the downsides of not staying on top of blood work? Maybe like, I know there's 1,000, but maybe it's your top ones that, you know, you see up from your end for people not monitoring certain things.
Yeah, I mean, for sure. And like as Tanner was saying, I think like genetics play a big role in that. So we often think of genetics are how much muscle or your symmetry and your insertions, things like that. But there's also a genetic component to how many drugs you can take, you know, and your tolerance to them. So I have seen people come in telling me they're on crazy cycles of, you know, like tren and orals and things. I'm like, your blood work looks pretty damn good. Like that's genetically somebody who can tolerate it. And then you've got other people who at 300 milligrams of testosterone, their lipids are skewing, you know, they've got high blood pressure, et cetera. So important things I would say to look at is like baseline. Definitely, well, first, if you're one of those kids thinking you need TRT, first just see your testosterone and look at your levels of total and free and see if you even need TRT. And I would certainly hope that you've maximized and tried to exhaust your natural potential just via nutrition and, you know, training. And then to look at blood work, lipids are a big one for me. I'm pretty aggressive when it comes to lipid management and doing some in-depth lipids. So looking at things like ApoB and LP(a) at least once in your life, getting a CRP to see like your kind of state of inflammation. I think addressing your thyroid function is super important too. Some people may have thyroid issues and kind of inappropriately be thinking that it's a testosterone issue. And, you know, bodybuilders don't usually make this mistake, but lay people, I don't think they think of thyroid as only being like a fat burner, you know, but bodybuilders have known for years, like a lot of guys will throw in a low dose T3 in the off season because it's anabolic to some extent. You know, it helps with nutrient partitioning. So if your thyroid's skewed, you're going to have a hard time with protein synthesis. Want to make sure your liver health is optimal, especially if you're going to start orals. And it's funny, when I was coming up, liver is all anybody really talked about. And liver is the only thing I ever thought about, like, oh, just liver, which is funny because liver actually repairs itself pretty easily. Some, you know, a transaminitis, a transient one, so elevated liver enzymes isn't that big of a deal. I don't want to say that as, you know, but like usually it will reverse itself. So kidneys are the bigger one that you really want to make sure, especially just due to how much water retention a lot of these drugs cause, which and vasoconstriction, which lead to you know, higher blood pressure and a lot of strain on the kidneys. So also becomes difficult with bodybuilders because they're probably supplementing with creatine, eating a lot of protein, just breaking down creatine via working out. So they're going to have elevated levels of creatinine. So their kidney markers are skewed from the get-go. So that's why it's important to get some further testing like a cystatin C or SDMA or both ideally, and kind of look at kidney function before ever starting. I think that's huge.
Do you ever have people just on the kidney? And I want to go back to some of the earlier markers too in a minute, but do you have them do the EGFR tests? Like how long is that again? I'm just drawing a blank now all of a sudden.
So the EGFR is just the estimated using like either creatinine or the cystatin C. The other, like the 24-hour urine and everything. Yeah, no, not usually. Usually, like I feel like a cystatin C gives a good enough marker. I mean, if a cystatin C and EGFR are coming back, at that point, it's just like you need to go to a nephrologist. I'm not gonna, you know, mess with trying to interpret anything further. But a cystatin C is great for that.
Got it. And then as far as lipids go, can you, just for people who don't know what some of the lipids you were talking about, you know, can you unpack those a little bit? You know, what are they? Why are they important at least once a year, or excuse me, once in your life to get, and, you know, what they're associated with?
Yeah, so the one that you should get at least once in your lifetime is called LP(a) or lipoprotein(a). That's a protein that you either genetically code for or you don't, but it's a highly atherogenic protein, meaning that it's one that creates a lot of plaque. So I think, you know, we've all heard of the marathon runner who's super healthy and had perfect blood work his whole life, and then he drops dead, and then they find that he's got probably like LP(a), which it really makes you susceptible to cardiovascular disease. I would even argue that if you have elevated LP(a), you should reconsider even trying to bodybuild, because you've got a risk factor. Otherwise, I mean, it is a risk factor. What I usually tell guys, if they have it and they're not pursuing PEDs or something, we can't do much about it right now. There's drugs in trials right now that maybe will, end up being beneficial for it. But I basically tell them it just means like you don't have any leeway. So you can't really let your lipids get out of range. You don't smoke, keep your blood pressure in check, all that stuff. But if you have high LP(a) and you start bodybuilding and skewing your lipids, like you're just, it's a recipe for disaster.
So I was going to comment on that, because for the lifters out there listening, or the people that think like, well, I lowered my dosage, or I'm not on gear anymore, I'm good. And they're maybe in the phase of life like I'm at. I can say this because he said this on podcast, so I'm not talking about someone's medical history here, but Pete Rubish has talked very openly about that marker being high. And I know on Table Talks, I think on our podcast actually, and he was saying how he just didn't know. If like he would have never tested it, he would have never known, because everything else was coming back fairly good. And now it kind of got, he's got a young family, and it just got his attention a little more. So I think there's a lot of those, I don't want to call them hidden markers, because to the general population, or the average, health person, they're kind of more, maybe they're not as familiar. I think social media is helping get the information out there, but they might not be as familiar with it.
No. Yeah. So that would the LP(a). And the reason why I say, at least one time in life is, like I said, we don't really have any drugs or anything that can lower it. There's some thought that like aspirin and niacin and things can lower it, and it may lower it to some extent. But the problem with anything like that is that just because it lowers it, we don't have any proof that that's clinically significant, meaning we don't know that if you lower it a little bit with niacin, that's going to reduce your risk of heart disease or anything. So in my opinion, rather than flushing every single night with niacin and trying to budget a few points, just, realize that you have it and treat all the other treatable things that you can. Probably the most important one to look at frequently, I would say even quarterly, especially if you're bodybuilding and actively abusing or highly using PEDs, would be ApoB. ApoB, or apolipoprotein B, is the protein that kind of wraps around like LDL. So we have a little bit of lipid chemistry here. We've got like high density and low density lipoproteins. And so that's HDL and LDL. And everybody kind of says things like healthy cholesterol and non-healthy. And that's kind of erroneous, because there's only one cholesterol. The cholesterol that's in HDL is the same cholesterol that's in LDL. The difference is kind of the protein build or makeup of them. So there's ApoB, which kind of wrap around the LDL containing, or ApoB containing particles that have LDL in them. Those again are atherogenic, so meaning they'll stick to defects in the arterial wall and the endothelium, which is that inner lining of our artery, and allow that fat to go into the artery, which then mounts an immune response, and then our body trying, to get it out of there, basically forms plaque essentially. So it's a big long cascade, but that's kind of what happens. So you want to look at ApoB, because that's capturing all of those like atherogenic particles. If you're measuring ApoB, you really don't even need to look at LDL. I mean, I still like to, because it's interesting to see, but I mean, people like Peter Attia kind of, he talks about an ApoB of 60 or below, which the literature kind of demonstrates will basically prevent heart disease. It's something that at that point, you just literally don't have the material to create plaque. It's going to be really hard to get an ApoB of 60 without pharmacology. Sometimes I see guys come through with just genetics that allow them to do that, but usually some type of lipid lowering agent will be necessary to keep it down that low. And if you're using some orals and stuff that, kind of skew your lipids, then I would say definitely throw in a lipid lowering agent.
Got it. What about you, Tanner? Any initial, I have a list, so I will just keep going selfishly. So I want to give you time to jump in.
Yeah, no, of course. I actually was curious about what kinds of pharmacology you might be thinking to intervene with, especially in the population of bodybuilders. I know that there's certain medications that wouldn't exactly be as compatible with their lifestyle as others would be. So what sorts of things would you use to better modulate cholesterol levels in bodybuilders and help them with those markers?
Yeah, I think ezetimibe is a great base for pretty much
Yeah.
everyone. So
Yeah.
I love ezetimibe, especially for the bodybuilders. I've been taking that now for probably 5 or 6 years. Started back when I was using more PEDs just to help with that. Why I like ezetimibe is that it doesn't come with the side effects that others like statins do. So the fear with statins is that it can cause muscle soreness or stiffness and cramping. And obviously, if you're a performance athlete and using your muscles, you don't want them sore and cramping all the time. I will say that I think that fear is kind of widely exaggerated. When you look at the literature of statins, it's around 5% of people, less than 5% of people get side effects. The way that they're kind of demonized, you would think it's like 95%. I know I kind of certainly did before looking at the literature, and I'm like, wait a minute, there's only like about 5%. That's crazy. So a statin may be needed too, but with ezetimibe, you can lower the dose of a statin and the frequency of a statin. So a common stack that a lot of people get really good results on is like 10 milligrams of ezetimibe, which is kind of a standard dose, and then maybe 5 to 10 milligrams of rosuvastatin 2 to 3 times a week. And not medical advice for anybody, but that's what I see a lot of guys using and get really good results with minimal side effects.
Perfect. And then, yeah, to Joe's question, I think, because I can take this from the younger generation, there's a lot of guys who want to hop on, I would almost say like stepping stone PEDs. And so for them, that would be SARMs and other things of that sort. One of the main things is if they are going to be using SARMs, of course, like managing your liver health is super important. And then also, if they're going to be using SARMs alone, as in without any sort of testosterone base, then they start running the risk of testosterone suppression. And if that's at a young enough age, as in like during their developmental years, or at high enough doses, then they could end up needing TRT for life. And that's a situation that a lot of guys don't really realize that they're signing up for when they're using these things that they picked up from their supplement shop or some sketchy website online. And for purposes like that, there is at least, selective estrogen receptor modulators like enclomiphene, which can increase their LH and FSH to bring up their natural testosterone production, possibly to the point where they don't end up fully suppressing themselves. There are obviously other side effect risks that they need to be aware of if they're going to be proceeding down the path like that, but that's something to keep in mind. And also just knowing what your testosterone is. I have a lot of guys in my direct messages that are saying like, I feel really sleepy all the time. I feel tired. I think I need TRT. You have no idea what your testosterone levels are. What kind of chronic fatigue and what could be causing that. You're just guessing. And you honestly probably see the flashing lights of TRT on social media and you think, oh, I want some of that. I'll just tell my doctor I'm tired and get on that. It's a nightmare.
Absolutely. Man, if I was just talking to my wife the other day, like if I could go back and I was like looking when I was 21 or even younger, 18 through like 23 or so before I think I went on around 22, 23, but I would have definitely hopped on TRT because I felt like shit every single day. And looking back, there's no question why. I was talking to her, I'm like, man, I used to get up for work at like 6 a.m. and work all day and then like really eat kind of shit throughout the day. And then we would go to the gym probably at like 7:30, 8 at night. And then I would go eat and it would be, eating at like 10 and then I'd stay up until like 1. So meaning I'm getting like 4 to 5 hours of sleep max and I'm just eating like trash. And I felt terrible all the time. I remember like when I was 18, I worked at this like hotel and I would literally walk into rooms and just like crash on the bed, like zonked. And I see these younger guys talking to me like, I've got fatigue, I've got low motivation. And I'm like, do you have all this dialed in? Yeah. And I'm like, I highly doubt you have all that dialed in because just being young is like kind of like counter to a lifestyle that's conducive to feeling good. Like, when you're 18, you're probably not going to bed at 9 and waking up with the sun and getting some sun exposure and doing walks after meals. And, you're probably not doing any of that because it just doesn't really work out. But yeah, I would have certainly hopped on because I would have seen like, oh, this is what's making me not feel good. But really they should work on lifestyle.
Yeah. I think, I know she's not a physician, but I know Allie Gilbert. We've had her on, and Allie really well. You're going to be at her Silverback. Thank you. I almost said Gorilla. Yeah, Silverback Summit, right? So, yeah, this looks like an awesome lineup. But she talks about like training for TRT, like before you get on. She talks about like getting your house in order, sleep, getting in good shape, things like that. I think that's a really good message too, because what's been scary to see, as you mentioned, is somebody who gets on and maybe they have a poor lifestyle, high body fat, poor sleep, but then let's say they start to change 6 months, 7 months later, but never get follow-up blood work. Like they might they might not need as much as they were taking before, because they're, the body changed so much because of all the, other lifestyle changes they did, to where if they would have did those lifestyle changes first, then maybe
Yeah.
they could have got there naturally or through less of an intervention, so it's just really interesting to see how that plays out.
I honestly think too, kind of probably the converse of what you said. I think as people get healthier, they can tolerate more. And so, that's why a lot of younger guys who are bodybuilding, like they've probably built up a good base already. They're probably pretty metabolically healthy, probably pretty lean. And so they do tolerate some of the higher dose as well. But if you just think about, like, an unhealthy body usually doesn't produce much testosterone. There's reasons for that. And that's why Ali likes to do that GPP for TRT, getting people ready to accept testosterone. Their body's not producing high testosterone for a reason, because it doesn't really work very well in a highly inflamed, metabolically unhealthy body. Our body doesn't really do things by consequence or by coincidence. So I'll tell people, it's like having this junker beat down car and you're filling it with premium fuel. Like, it's actually worse for the car than if you just gave it unleaded. So that's what's happening when people are just fat, they're not taking care of themselves, and they give themselves TRT. That's when we see issues with gyno, because their aromatase is so high. They're dealing with high blood pressure. Their hematocrit and hemoglobin are sky high. I don't usually see issues like that in somebody who comes in who has a nice fasting insulin. They're metabolically healthy. They can actually tolerate a little bit more because they have a healthy body to accept it.
Yeah, I was gonna just to kind of thinking about, there's a lot of different ways to go. So, but one of the things, just with your, experience, because you would see a lot of diabetics towards the tail end, right?
Yeah.
And now you're seeing kind of more like, obviously with your background and with your, the kind of optimal living space, when you're looking at, let's just say, fasting blood glucose, like what is a general range for a lot of people to shoot for, that you would say is more like that optimal health range that you'd like to see people in?
So I personally don't really like fasting blood glucose at all, especially when people are taking it first thing in the morning. It's often a little bit high due to morning gluconeogenesis. And then they, if their doctor or something sees it's 100, they freak out. So like, if you've ever worn a continuous glucose monitor, you'll see there's something called the dawn phenomenon. I don't know if you've ever heard of that, but right before you wake up, our body, our cortisol levels rise, which increases our body temperature, and that wakes us up. Well, that increase in cortisol also stimulates gluconeogenesis in our liver to start pumping out glucose and make it higher. And teleologically, it makes sense. You're about to wake up. You don't know when your next meal will be. Our body produces some fuel for everything. So first thing in the morning, blood glucose is actually a little bit higher. I would prefer a continuous glucose monitor if you really care about that. So I would prefer more of like an A1C or a fasting insulin. I think fasting insulin is great because we know that as the insulin, like, you really shouldn't be producing high amounts of insulin without having eaten some type of glucose or even protein or anything. So there shouldn't be high levels of fasting insulin, and that's indicative of insulin resistance. And insulin resistance can precede pre-diabetes by sometimes a decade or more, meaning that you're getting, this perfect A1, or not perfect, but decent A1C of, say, like 5.3, 5.4. Your doctor's telling you you're fine, but actually you still have insulin resistance. And that's my pushback a lot of times on, like, the healthy at every size community. They say like, oh, people can be obese and healthy. I'm like, really? I doubt it. I bet they do have some sign of, like, insulin resistance occurring to some extent, or some low grade inflammation or something. So yeah, that's kind of a long answer, but fasting glucose isn't my favorite, though. Obviously anything from like 80 to 100 is kind of normal.
I think you hit on something there, and I just wanted to comment on, to get your experience on, when you're looking at fasting insulin. Is it do you use one marker, or do you do the testing? I want to say it was and again, this is a couple years ago, I used to see it, but they used to run like a fasting glucose, or a glucose test, like a 5-hour or whatever, with an insulin overlay. Is that what you typically do, like a longer, or 2.5? I forget the time period. So I think it's like a
2 hour. It's a oral fasting oral glucose tolerance test. So yeah, those are great, and I wish we did more of them. We don't at Merrick, I think, just due to I think those are usually done like with inside a provider's office, and we're just sending people to LabCorp. I don't know if LabCorp has the dextrose or glucose, whatever they use to give. I think that usually occurs in a doctor's office. That would be awesome, because that's a really good way to test. Like, let's see, obviously you want a glucose spike, and then you want that to drop within a certain range of time. Like by 2 hours, you should be back to baseline. So yeah, combining that with a fasting insulin is awesome for sure.
I did, because one family member I had did that, and again, this is just, I'm going off of memory, so feel free to correct me if I'm misexplaining this for our audience. But what I recall is their glucose was good, but in the background, the insulin was going crazy, like to regulate it. In other words, it was a sign of an early onset of like some insulin sensitivity issues. So you said earlier, it could be a decade ahead of time. And I thought that was really interesting, because all their other markers were really good, but they were having trouble with, specifically with like, fat loss, weight loss, weight fluctuations were pretty fine, but just, they felt like they've been carrying a lot more, body fat and just more inflamed at times. I just found it kind of interesting how that came about. So.
Yeah, for sure. Insulin's inflammatory in its in and of itself too, and insulin, having insulin resistance will usually lead into like non-alcoholic fatty liver disease. Usually the sequence is something like insulin resistance, non-alcoholic fatty liver disease, and then pre-diabetes. So, in your gen pop, you'll usually see those issues first. And like I said, most doctors, you just aren't looking for those things. So they're just testing an A1C, and that's coming back fine for years. But actually, there's something brewing underneath that needs to be looked into.
Got it. Tanner, any marker insulin questions you have on the topic?
Yeah, I mean, I think I would go to the point of intervention. So for example, especially within my age demographic, it's really popular for a lot of people to be using MK677. I have seen that really thrash fasting blood glucose levels and just insulin sensitivity in general. Seen a lot of guys get fatter and flatter very quick on something like that, especially if it's not modulated correctly. So if someone is going to be using something like that, or growth hormone, or any of the secretagogues, what sorts of things might they want to combine with that in order to keep themselves healthier while on that?
Well, Joe, did you guys glucose disposal agent come out yet? The berberine one?
We do have it. Yeah. Suppressor.
Nice.
Yeah. We do.
Yeah, I remember last time I talked to Justin, that was in the works. So,
well, our new version actually will be in, by the time this recording is released, it will be out. So I could say yes.
Okay. There we go.
Really soon. Okay.
Yeah. So a couple days.
That was a perfect plug. So yes,
good looking out.
Something like a berberine, I think at least, but maybe even more like a metformin would be good. I personally like metformin. I'm not super afraid of it. I know some of the bodybuilding people are, due to fears of it, like reducing IGF-1, but like you said, you're taking like MK677. It should theoretically be really high anyways. You're probably counteracting that, and 500 measly milligrams of metformin isn't probably going to overpower the MK677 and impact that. I'd also like push back on the literature that says that it caused, an inability to put on muscle. Like when you look at that study, is not for our demographic. It's like, I think it was 1,700 milligrams of metformin in guys who I believe were above 65 years old and eating like, hardly any protein a day. And they're like, they didn't put on muscle. And I'm like, what a surprise. It's not the 18-year-old dude on MK677 doing everything else right. So maybe throwing a little bit of metformin to help offset that.
And did you have any opinions on SGLT2 inhibitors? I know that I've heard those kind of circulating around nowadays.
Yeah, for as far as like longevity, I think they probably have a lot of utility, even beneficial in kidneys. I would just say like things like that. Metformin, I feel like, is a little bit easier to just like, I don't want to tell anybody to do this, to take it without supervision or anything, but something like canagliflozin or something, I wouldn't say just go try to take that on your own. Like you're really messing with your electrolyte balances and everything. And that's same with like insulin. It's like you're getting into risky territory at that time. Like metformin is going to probably be hard to really overdo. You're probably not going to get hypoglycemic and run into issues. But so, yeah, I think that they have a lot of promise if, used under supervision, especially in like kidney health and just longevity in general, in gen pop or in bodybuilding populations.
Awesome.
Yeah. And then just to one thing too, I forgot to mention, Tanner, like to those guys, going back to the SARMs who are using SARMs at a young age, like that, those are the most suppressive thing I think that I've seen. So I've seen guys who say that they did cycles of anabolic steroids like TRT or testosterone rather, or Anavar and some things, and they're usually recovered pretty well. But the guys who come in who say I did a cycle of SARMs when I was 18 or something, they have long-term suppression. I don't understand it. I wish it was, there was some literature on it that talked about it, but they seem to be like very detrimental in the long term. These guys don't recover very well. It's kind of crazy. And in my opinion, I think the gains are probably inferior. So, if you're going to do something and you're going to get long-term suppression, why not just do the hormone your body already makes that we have over 100 years or almost 100 years of literature on? Like I would prefer to just do some testosterone over SARMs personally. I think SARMs are promising in the future, as research continues and we really dial in some. It's a really cool idea, but where they are right now, I just don't think they're great.
Seems to primarily be an accessibility issue. I mean, especially if you imagine being a 16-year-old in high school, the last thing you want is your mom coming into your room and finding a bunch of needles and like all these vials. That's a bit hard to explain, even though you're saying, no, wait, mom, it's less suppressive, I swear. I don't think that would exactly go over very well. But I think there's just that culture of like wanting to rush things where it's like there's always that enhancement. There's always that booster that they could get. It's a bit unfortunate, really.
And I remember my first, when I was 16, my first kind of dabble, I was really afraid to get some creatine. And I went to the one big dude in school who I was like, can you get me some creatine? It was like, like now I know the dude brought me fucking like GNC banana flavored protein powder and put it in a Ziploc. I didn't know because I didn't know what creatine was, but now I know I was mixing up this creamy substance that was fucking whey. And I was like, I remember I was so scared too for creatine. Like times have changed so much now that it's crazy that people are doing these intense SARMs or even testosterone stuff. When I was like shaking, pouring out creatine, like, oh my God, and my friend and I were like, we're going to get so big. We're doing creatine.
Gosh, I remember Vanadyl sulfate was like a big one. I don't know if you ever remember hearing about that one. It was like just the Vanadyl, like it gets you pumped. And then there was these giant amino acid tablets. Like you could take like one every 6 hours because they were so big. It was just like, if you didn't die of choking from it. And I just look back and now all the powders and the flavors and the delivery systems, I'm just like, oh my gosh, I can't believe like that stuff, how much money it is probably peed away.
It was the Wild West back then. I mean, that was like when Superdraw was on shelves at GNC and stuff. That's unbelievable to me.
That and a version of GHB was in GNC also back in the late 90s. So, which is crazy. People were taking it to sleep and started to get high from it. And the rest is history. And,
it's weird. It's kind of like, like clothes, like people are wearing things from like the 80s and 90s. Like, I feel like gear is kind of that way too. Like Joe, earlier when you said like 250 used to be a cycle. Now I feel like that's becoming kind of in vogue again because we got people like Derek and stuff who have kind of promoted these like start lower and be responsible. But so when you were doing that, 250 was a cycle. When I came in, nobody was thinking about anything lower than 500. Like 500, everybody started with. It was 500 with a D-ball kickstart. And now we're smarter again. Now we're smarter again. And I am very impressed with a lot of the kids who come in who do say they want to start something. And they usually tell me something like 250 testosterone or maybe 300. And I'm like, this is impressive. Of course, like I will help you however I can to keep you safe and healthy because that's not what we were like when I was getting involved.
It is really reassuring to see a lot of younger guys start to actually really understand things. I know that I was talking to, I think I was on Paul's live stream on AB Live. And one of the callers that came in was saying how he was prepared to do a semen analysis and all this stuff before he was even going to touch testosterone. And to hear an 18-year-old person say something like that is just really gives you a little bit of hope for the future, as opposed to, the various DMs you'll get about, my buddy gave me a vial of Tritren. Is it fine if I just start slamming that for my first cycle? Like my head hurts.
Yeah. And I'm just like, there's no excuse. Like I at least feel like when I was coming up, I had an excuse. We couldn't just, Google that and see YouTube videos and podcasts like this. They just didn't exist. I found forums and that was how it worked on forums. You would try to find who was ever the smartest, it seemed, and then try to hit up their DMs. And then like, I remember I sent a picture of my first vial, like, is this legit? And they're like, no, that's no good. You should buy from me. And I'm like, oh, okay. And I didn't know any difference. And so then I buy like a vial of, like 10 milligrams or 10 milliliters of testosterone for like $100 from some asshole who probably, it was the same bunk stuff. But nowadays there's so much information. Like I said, you got podcasts like this, you've got, Derek Vigler, Steve, got all these great people who are putting out content. You can go to places like Merrick Health. There's literally no excuse anymore. So when I get those DMs, I pretty much just delete them because I'm like, there's no excuse for your stupidity. Like, next. Right. I mean, I really like to work with those guys who are open about it. Right. My least favorite person is somebody who comes in and lies. And I'm just like, it's like so frustrating to me that, like, I had this dude the other day who came in and the guy's like, he's jacked. He's way bigger than me. He's got a full like facial beard and his testosterone's like, 150 or 200 and LH and FSH are suppressed. He's like reaching across his body and his triceps taking up the whole screen. And I'm like, any reason why your testosterone would be this low? No, I have no idea. Never taken anything. Nope. I'm like, it'd be better if you did, because then I would have a reason to prescribe, Nope, never did. And I'm like at that point, I just like, you're lying to me. Like, how can I trust you to, So like, for those listening, like, don't lie to your coach or provider or anything, it's a lot better just tell the truth. And we've been there and we understand. And if you're with somebody who you feel like you need to lie to, you need to find somebody else, I would say.
That information age that we live in right now, it does provide a lot of benefit to, just like what you're saying, there's really no excuse to not be educated. But then there's also a lot of people who kind of, just like the guy that you got a call with, they're lying through their teeth on social media, on public places. You were just saying earlier, like, guys are like, yeah, it's just TRT. TRT doesn't exactly make you 300 pounds of muscle at 5'7". That's not really how this works. And it really sets a damaging perspective for younger people looking to get into this thing, because they don't know what kinds of risks and damages they're doing to their bodies. And they also don't know the kinds of things they're doing to maintain their health while on it. So at least if you can admit to inducing a lot of stress and strain on yourself, then that also opens the door to, hey, I am also doing this, this, and this for my health. I'm working with this clinic in order to keep myself healthy, these doctors, these practitioners, to create more of a dialogue around that, instead of pretending to be healthy by pretending to take the small doses. It's not actually doing anyone any favors, unfortunately.
Yeah, for sure. And something I like to really try to impress on people is like how ineffective a lot of these drugs actually are. When I try to talk about my experience is like, I really redline things as far as the gear goes, and my physique was never that impressive. Sure, it was better than most of the guys at the gym, but like I said, I wouldn't have even been able to win a local show. Some dude with better genetics would have crushed me, better genetics and better work ethic. And so if you don't have those two things, the amount of gear, it doesn't matter how much you do, you're never going to, make much of it. And so like I'll talk about my first cycle, I was really disappointed. And it just was like, it led to this weird denial of like, oh, I didn't do enough, or that wasn't good enough gear. And, so I just kind of spiraled from there. But then it wasn't until probably like 4 or 5 years into the game that I actually dialed in my training and my nutrition and did the lowest amount of gear ever, that I blew up and had a respectable physique. And I'm like, that was a secret the whole time. Who would have thunk? It was just, I had to eat a good amount of food and train really hard. That's crazy. Because I just kept thinking like, oh, if I do 3 cc's like Boston Lloyd said the pros do, I'm going to grow. And all that got me was feeling like shit all the time and a ton of scar tissue. And, I actually felt so bad I couldn't work out a lot of times. I remember, being on trend and stuff and going like hypoglycemic, even though I just had a ton of pre-workout carbs and feel like I'm going to pass out. And then your back's so pumped that you can't even do a leg press, and like it actually ends up being detrimental to your gains sometimes. So until you figured out everything, like, and that how to build muscle without it, I wouldn't even start.
Yeah. I mean, I remember spending a lot of time, like it was me, Justin, and Steve Kuklo trained together for quite a while. And and Steve was a teen. I just came out of teens. Yeah, I think I was 2 years older than him, maybe 3. But anyways, my point is like we were talking about like hacks to get more food in, or what the new buffet was that had like the grill at it so we can get lean meat or whatever. And I remember getting yelled at, me and Justin, because we went to the movie theater and we had like a couple 12-inch subs with like massive meat, and it stunk so bad and all that. But it was just, that was the mentality. And everyone around us was like, we were at a pretty we didn't realize it at the time because we were kids, but a pretty, prominent gym. A lot of good competitors came out of it, but the upper tier competitors that came out of that gym, everyone was on the same, if not other people were on more, but there was just a small group that were growing a lot each year. And it was just like, nothing changed. There's no new chemical or new amounts that anyone in that core group that I knew. There was quite a few between men and women that went pro in a very short time, but it was, but I did want to transition back to peptides a little bit, because we were talking just kind of for that older, I say older, because Tanner's on here, but that older population, the 35, the 40, the 45, the 50 and up. What are some, or are there some common peptides you see that are just helping people who are, on beyond their competitive lifestyle, or the time frame, if you will, and they're trying to just stay optimal life, young, less pain, more active, things of that nature? Are there any peptides you see out there that are promising or that are showing some really good results?
Yeah, so there's a ton of different peptides, and I think they all have their own utility in certain circumstances. The ones I'm probably most excited about are the healing peptides like TB500, BPC 157. I think those are great for more of like acute injury. There's even interesting talk of them being used in like brain injuries and things like that, which is pretty cool. And I think that's a promising area of further development. But those are great for more of like acute injury. I will get people who come in with like an arthritic knee or something and ask, is BPC 157 going to help? Probably not, I would say, because that's like an actual structural issue where you have cartilage that's worn away that isn't going to grow back, and now the bone is essentially fusing together, and that's what arthritis is. And the BPC 157 is going to help that. What it will help though is like a shoulder sprain, or like an elbow tendonitis or tendinosis, where you have this soft tissue kind of injury, and they'll basically promote more growth factors and things in the area, increase blood flow to the area. That kind of stuff is cool. Then you have the other peptides that essentially are around like growth hormone and IGF-1. So growth hormone releasing peptides or growth hormone secretagogues, GHRPs. And I have mixed feelings on those. I think a lot of people just hop on and I really hate when growth hormone is talked about as being a longevity aid, because when people talk like that, I feel like they don't fully understand actual longevity physiology and biochemistry, because true longevity people out there, I mean, you talk to somebody like a David Sinclair at Harvard, he'll probably brag about how low his IGF-1 is, not how high it is. Because when you look at like what keeps in like a worm or something alive longer, I'm using a worm because they usually research those for longevity. It's those with lower IGF-1. So for a clinic to say that this is a longevity drug is like the exact opposite. What it can help you to do is have more vitality and maybe a better, what we would call like health span, not just a lifespan. So yeah, it will improve your hair, skin, and nail quality kind of acutely, maybe help with recovery, maybe help with reducing some body fat. And that's great, but I don't think it should be overdone. So I think that, I personally wouldn't go on like a low dose growth hormone just forever, or a GHRP kind of indefinitely forever and always be redlining or keeping my IGF-1 at the high level. I think it's good to have pulsatile high when needed. So when your recovery is taking a hit, if you're in a certain part of your training program that your lifts are getting heavy and you're starting to ache and your recovery is sore, perfect time to add it in. Or you're training for whatever, even if you're just a guy like older and you're training for your vacation, cool, add it in for the 8 weeks leading up to it. But I don't really like the idea of just hopping on and staying on indefinitely.
And so you'd still phase that for a roughly 8 weeks or so, as far as like the time frame, you'd kind of still not like a week or 2 weeks or something like that. It'd still be a little bit of
it could be
block.
much longer. Yeah, even probably up to like 16 weeks is probably fine, in a long scheme. But sometimes you hear people coming in with this boom of these like anti-aging clinics, and they're like, oh, my doctor's had me on 2 IUs of growth hormone for the past 5 years. I feel great. I'm like, cool, but that's not true longevity. We could be increasing your chance of, tumor growth and things like that. So that's always a little scary to me too. Like I have a family history of melanoma, and that is involved in that IGF-1 pathway. And so it kind of freaks me out, all of the growth hormone that I did in the past. Like, did I stimulate any tumor growth? Maybe, I don't know, but that's always a possibility.
I do work with a peptide brand, and so there's a couple that I've heard about and that I've seen a lot of popularity with. One in particular, MOTS-C.
Yeah,
MOTS-C has been a pretty interesting one.
super cool.
Yeah, anything kind of along those mitochondrial lines that people can leverage. It seems really, really nice as far as, I mean, I know the term anti-aging brings with it a variety of different connotations and
Definitions,
whatnot.
yeah.
But Vigorous Steve, someone I'm good friends with now, has spoken very highly of it. He's quite enjoyed the use of MOTS-C. Many of my followers have as well.
Yeah, exactly. So I think just to go back, like we're talking about types of peptides, like there's so many
Right.
different peptides, like insulin's a peptide. So when we say peptides, though, I'd say the bulk of people think of growth hormone peptides or healing peptides, but peptides like MOTS-C, I would say that's a true longevity aid because it's increasing or enhancing mitochondrial function, and anything that improves the function of our mitochondria is great. That's basically, like the fountain of life. So yeah, MOTS-C is great. I don't have a lot of like familiarity with it. I kind of know it peripherally, and it's something that I think is super cool, and I hope eventually gets a lot more like literature done on it and everything. I like it. So yeah, that's a great one.
Is that something now that you, I don't know if this is something that's studied, but do you build like a tolerance to it at all? Or is it something that has to be rotated, or is it just a continuation that MOTS-C?
I have no idea, actually. Do you know, Tanner?
So in Steve's experiments, I believe he was using it consecutively for a while. I don't know if he's pulled it out yet, actually. So maybe he plans to use it indefinitely. Maybe knowing him, he'll probably experiment, remove it for a little bit, see if he gets a difference, and then get back on it. I believe that remains to be seen.
Yeah. So I don't know if like tolerances get built up. I would assume probably not. Usually things that like, I can't think of like feedback loops built into mitochondrial function. So, I mean, that's like the question comes up with like supplementing with pregnenolone. Is there like a negative feedback loop? And if it's produced in the mitochondria, there's not really a feedback loop back into the mitochondria. So my answer for the pregnenolone one is probably not. So with that too, I don't know, maybe, but I'm not sure.
That actually reminds me of something else with long-term testosterone use. Are there any, and I'll throw a few out there, but are there any other aids someone should use because of maybe some other, I'll just say chemicals that are not being produced because of the, exogenous testosterone you're taking in, say like a DHEA or pregnenolone? Like, should that be in a protocol, or if not, or maybe after a certain time, should it be in there? I've loosely heard, not my area of, even I haven't really looked into it. I just kind of overheard something with like neurotransmitters and things. I'm just curious. I'm again just going on a fishing expedition here with that question, but
yeah, no, it makes sense. So DHEA and pregnenolone are neurosteroids. So that's probably what you've heard. And
sure.
they're also precursors to testosterone. So when you look at the pathway of hormone or steroid synthesis, you start with cholesterol, and then you get pregnenolone, and then you get everything else. And DHEA is between pregnenolone and testosterone. So the idea is that if you suppress your testosterone production, you're probably suppressing kind of the pool upstream. It doesn't necessarily work like that, though. And that's been a very lucrative thing for clinics to say. I think everybody, throws somebody immediately on DHEA and pregnenolone alongside their TRT, telling them that you're going to get suppression alongside of it, which very well may be, but there's also people who it doesn't happen to. Right. I also think like the hard part with pregnenolone is I'm not a fan of the way that we tested. Sometimes it seems so erroneous, and there's probably better ways of testing it, like the Dutch test, the dried urine test.
Yep.
Yeah, that's probably a better way to measure it than the serum blood levels. But pregnenolone and DHA are tricky. You have to work with somebody who actually really understands them, like a provider, and knows what to look for. Interestingly, guys who have used SARMs at a young age, or even PEDs at a young age, usually will have suppressed neurosteroids. And then even if they recover, they have low DHA or pregnenolone, and are having very similar side effects or symptoms that they would have like testosterone, even though testosterone's fine. So the answer to that is yeah, like they can be super beneficial in with TRT. They're not always needed though. And if your clinic is just telling you out the gate to take DHEA and pregnenolone, I wouldn't, because they can also convert into estradiol and things, and there can be an issue downstream. I personally really like them. I found that after my years of use, there came a time when I literally felt like I was just getting stupid. Like, just, you know, frankly, I felt like my verbal acuity was terrible. I didn't have any mental recall. I'm sitting there talking to somebody stuttering, lost for words. And I'm like, I know what I'm trying to say, but it's not there. And I didn't ever think to look at my neurosteroids. What I did, my DHEA and pregnenolone were non-detectable. So supplementing with those really helped. That was one thing that I really noticed a difference in. So I was supplementing with nootropics and all kinds of things, and maybe a little bit of cognitive enhancement, but those were great. My libido was even taking a hit at that point. So yeah, if you're a guy who's been running high dose PEDs for a while, I'd get them tested. Other things that lower them are like chronic pain. So there's some people have like this intractable pain due to various, conditions that can lower those neurosteroids. Trauma, so like a very traumatic event. So all of those things can lead to it. So you need somebody who knows what they're looking at, though, to tease out if that's what the symptoms are coming from.
Yeah, no, that makes a lot of sense. I mean, I think, like you said, the focus part. I mean, even as you get into sleep and recovery and things. No, that makes a lot of sense.
Yeah.
Tanner, any other?
Yeah.
Oh, go ahead. Sorry.
Oh, I was just going to say, I wish that we kind of looked at them more. Most doctors won't pull DHEA and pregnenolone. Pregnenolone specifically, not even on like LabCorp's ranges. There's not even a range for it because no one really pulls it or knows what they're looking at. Though, like when you look at the literature, we've known for years that when you supplement with these things in the elderly, because just aging tends to deplete them, there's massive improvements in their cognition, and they probably play a role to some extent in neurodegeneration. So I wish they were looked at more, and young and old, and older people, can probably really get a lot from supplementing with them.
And it's probably just more testing the metabolites of it, right? Is it hard to get a good accurate reading in serums? So you have to kind of go the urine route to get the metabolites of it, or?
Yeah, I don't fully know all the chemistry behind the testing, but they just seem to be so inaccurate. I mean, sometimes, I'll see like a really high DHEA and then like no pregnenolone. I'm like, this just doesn't really make sense. It's kind of weird. And then people supplement with it and it goes down, and there seems to be a lot of inaccuracy. So the metabolites in the urine, which I don't really know how to read the Dutch tests, and I don't even know how much validity they have, but from what I've kind of heard from other experts and things, it's probably a better way of reading it.
Yeah, I saw a lot of value as obviously a non-clinician, just kind of an outsider looking at different testing with the cycle mapping, like just different, like the female hormones over time. That was really interesting me. And what was most interesting was at different times in the map, you could pinpoint how they felt, like almost like clockwork. And when I say you, not meaning me, but like a physician. And I was just kind of, cause I had some family members that had some women in the family that had some pretty major issues, were just looking for help. And that it could just be confirmation bias, that they just happen to line up for them. But it seemed to make sense to me, but again, not my area of expertise. So, but I did find that pretty interesting.
Yeah.
Tanner, any other thoughts or questions at the moment? Of kind of, I know we went a little down a little trail there.
Yeah, kind of on a similar vein to things that testosterone might be creating deficiencies in the body. Was thinking about testicular health and LH and FSH production being basically in the gutter for any steroid user. What sorts of things would you intervene with? I know, for example, HCG is very common. Now there's also gonadorelin and kisspeptin. HMG is also an option, or just straight up recombinant FSH. Even carnitine can help with sperm production. So with all these options, what are sort of things that you see the most success with, most popularity, things of that sort, or just like opinions on that topic?
Yeah, so that's one area that I don't think we have good knowledge on, is what are the long-term ramifications of so completely suppressed LH and FSH. We don't know if there's other parts of the body that LH and FSH act on that maybe we're natively impacting. It's totally possible. We don't know everything about every single receptor and receptor site. So that's interesting. And I hope that one day we do have more kind of literature on that to support that it's okay. Because I often wonder, I think that testosterone could be super safe. You're essentially giving a bioidentical hormone, but is there these ramifications from a reduction in LH and FSH? Are they working in other parts of the body we're not aware of? sure, maybe. And then when it comes to like testicular health, like you said in particular, that one's interesting because, you know, we all know guys in the sport who have a lot of kids and had no issue, you know, having children. And that's even with abusing high dose androgens, which can be toxic to the testy. So testosterone's been studied as a birth control. It's never been approved as a birth control because it doesn't work very well. And, you know, you can still have intratesticular testosterone and sperm production that's occurring despite their LH and FSH being suppressed. So that's where the sperm testing is super beneficial. And I personally probably wouldn't add in like a large dose of HCG if I was fertile already. There's some people, and I understand where they're coming from, that say like add in HCG will preserve neurosteroid cascades. So similar to what we were talking about with like DHEA and pregnenolone, there's a lot more that gets produced in steroid production than just testosterone. And if you're suppressing that, the idea is that you're suppressing neurosteroids. And so maybe that's why some people feel better on HCG, but I've seen it go the other way too. And some people feel awful on HCG, which, you know, it kind of makes sense. You're loading a female pregnancy hormone in a male, like that's not really supposed to be there. We do produce very small amounts of HCG, but very small amounts, you know, not these massive amounts that we give. So it's where with HCG, I kind of see people fall into three categories. One is they feel no different. It's just an injection that they don't see any difference of. Two, they feel a lot better. Libido seems to increase significantly, and that may be through those neurosteroid cascades. And interestingly, sensitivity down there seems to improve. So they say, you know, sex feels better. My orgasms are better. Obviously, their volume's bigger because they're, you know, stimulating the Sertoli cells to produce sperm. But then there's a third category where they feel terrible because it's, you know, predominantly driving higher estrogen levels and things like that. So it's always a little, again, work with somebody who knows what they're looking for. And if you're a guy who doesn't want kids or has had kids and done, you're probably fine to not have it in. If you're committed to this lifestyle and you're going to be on it forever, fine. I probably wouldn't add in. Like myself, I don't have HCG in. I did a course of it for the first time maybe 6 months ago just to see what it was like. And I was one of those people who didn't feel a thing. So I didn't leave it in. But yeah, and then there's other things, like you said, the recombinant FSH, that's great, just super expensive. But basically what you're doing there is just, you know, you're just using basically exogenous FSH to stimulate those. HMG is basically like FSH2. And then carnitine can help not with the production so much of sperm, but with the motility or the health of the sperm. So great. And when added in there. But I would tell people before you start adding in a ton of stuff, just get tested and see if you even need to do that. And if you're on TRT, you may not need to. I think the issue, though, comes with using higher dose androgens can actually be toxic to the cells and kind of cause a different type of actual damage to the testy than just testosterone suppression does.
Interesting. And now is FSH, is that being used? I just don't know this. Is that being used in a clinical setting? I've seen it on social media and stuff. I just didn't know if that's something that's common sometimes.
Yeah, we have providers and some who will be prescribing it at Merrick. I mean, it comes down to probably if the patient can afford it. So say a cheaper route would be something like enclomiphene, which Tanner brought up earlier, which is a SERM that's going to increase production of LH and FSH, and then mixed with HCG, kind of a combo of those is pretty common. You also mentioned like gonadorelin and kisspeptin, which I personally feel like are just a complete waste of money and are highly ineffective. And hope people listening to this, like when your clinic tries to upsell you on that, I would just not take it. Probably a year ago or so now, there was these various regulations with HCG, and a lot of clinics switched over to gonadorelin and kisspeptin and things like that, and telling people like, oh, you need this to keep your fertility. But if gonadorelin and kisspeptin should theoretically be increasing LH and FSH, I've never seen them be even detectable when people are using those. I mean, it's not doing what it says it does. And when you actually look at the literature, when it worked, these people had pumps inserted into their vein. So it was like a constant stream of it. So sure, it worked really well. And it probably does work when you inject. You probably get a transient, like 3-second increase in LH and FSH, but then you don't inject again for another week. It's not working. So they, in theory, mechanistically, they work, but not the way that we're dosing them. If your clinic is giving you a pump, then great, that's cool. But I've never seen that happen.
Yeah, with the restrictions with HCG, I mean, is that really kind of one of the only tools you have then, is like an enclomiphene or can you still use HCG at all in different forms or?
Yeah, I think you can use HCG. I think the issue is getting like you have to get brand name like Pregnel or whatever,
Okay,
and you can't like a compounding pharmacy. I don't know if they can make the compounded version that they could previously. So again,
more
ramps
of a
up the
money.
cost
Right,
unfortunately for the patient, which is just stupid. But
right, right. But they got to get
yeah,
paid, right? They got to
Yeah, that
pass
would
those
be
everybody,
regulations to get paid.
that would be
it's
the
crazy.
pharmaceutical route, and then of course there's a lot of research chemical outlets that are now getting a lot more popularity, especially for people who just don't have the funds to be able to afford, the pharmaceutical route. There's obviously quality concerns, but with young guys that I work with, especially, finances are such a massive issue for them that if they are going to pick something, I want to be able to provide them with something that is at least reputable quality. So one of the
Yeah.
brands I work with is they do sell HCG for that purpose.
Oh,
So
nice.
it's helpful to help them out in that regard. But obviously, if you have the funds to be able to get like legitimate Pregnil and you are actively trying to conceive and have a child, I wouldn't take my chances with the cheap stuff, I would say.
Yeah, I would agree. And then that one's actually like one of the ones that you can test purity of super easy. You just go get a pregnancy test, which was pretty well known when I was coming up. And then I guess people don't really know these days. It's funny because I'll have patients like, I don't know if this is actually working. I'm like, well, just test it, dude. Go get a pregnancy test, dollar store. Because yeah, I mean, HCG, for those who don't know, is what women produce and urinate out, and that's how we test for their pregnancy. So you should test positive.
Pretty easy.
Yeah, yeah. Just take one little drop and put it on, and then let it sit there.
Now, just I know we're a little bit past kind of the scheduled time. So, and I know you do this stuff all day, so I want to be respectful of that. But I just to kind of wind down a couple questions here. One that I wanted to get your input on was, are there? I've heard, again, you hear rumors, right? But it seems like whenever a peptide's working really well, here come the regulations pretty soon, or whenever something new. Are there any out there now that you see that are kind of on that orange list, soon to be red list? Like, we're not sure if we're gonna be able to get that, or anything kind of that's in some kind of studies or trials right now that has been used for a while, more off label, but you think is potentially going to be restricted, like an HCG or.
I don't know. Yeah, I don't fully understand how all of the regulations and things work, because a lot of these pharmacies pump out stuff that isn't FDA approved whatsoever. And you would think as a research chemical, stuff like Samax and Selenk, I don't know how we prescribe that. Like, honestly,
Sure.
I don't know. I'm not saying that we're shady or anything, but it's like I don't really fully understand the laws of it, and I'm sure somebody else out there does, but politics and law are not my specialty. But yeah, things like, I would say probably something like testosterone, because that's actually approved and produced, I believe, and used for like AIDS patients and lipodystrophy. So something like that actually has, some pharmaceutical company already making it. They usually have lobbyists and everything that will shut it down. So
Sure.
I think everything's at risk. I mean, I'm sure something like Mott C, because I think, didn't they try to shut that down? I believe, if I remember correctly, maybe a few years back or something, there started to become regulations on it and people were freaking out. So yeah, whenever anything works, they're going to try to, make money off of it.
And again, this is a few years ago, but I did hear BPC was in some level of trials a while back where they were trying to, get it to that level to where it was going to be more regulated or whatever the case was.
Yeah, and I don't know why it isn't more widely used and things. Is interesting because it seems so safe.
Right.
Like in orthopedics, like where I came from with, we're dealing with tendon injuries and things. Like the little bit of literature that we do have on it is like Achilles and mice. That's probably the best study that everybody cites, where they basically lacerated the Achilles tendons and then used BPC 157, and the healing time was dramatically decreased. And that would be awesome to use with some of my patients who have like Achilles ruptures or people I've done surgery on.
Yep.
And then even like the wound care we talked about, I can see it having a ton of benefit in the wound care world. We have a lot of cool wound care drugs, but something like that would just be another piece of the armamentarium, which would be awesome.
Yeah, and it's anecdotal, right? But I had a family member who was not going to inject, and they did oral BPC after knee surgery, and it was a very, very well-known surgeon in the area, works with a lot of athletes, and it was a third of the recovery time. And he was just blown away. He's like, "What is that stuff called?" And tried to like look into it more, and just never heard of it. And again, maybe she just got lucky, but it was just one of those things, because a lot of times people also would say like, well, you have to do localized injections because the oral doesn't really translate. And this person's like, not doing it. Don't care. If I'm going to try it, I'll try it this way. And it worked. So
Yeah, I mean,
well,
like Tanner, do you know much about like the oral versus an injectable? I think my biggest issue is we just don't have a lot of literature on it.
right.
Some people, somehow there's really intelligent people in forums and stuff. And if you're younger and in those, sometimes that you may have seen something. But my thought has always been like the side injection is probably kind of useless. Just when you know physiology, like it's going to get picked up by capillaries and then, make its way into normal circulation. And so side injections, unless you're actually literally injecting into the injury, like into the tendon, which no one's doing, they're just doing sub-Q. Like I don't see it having a ton of utility. You could probably just do it in the abdomen. I do wonder though, like, is it something like, we have antibiotics like say vancomycin. If you take it to work in the gut only, but if you're taking it for like a wound on your foot, you're going to need an IV because it doesn't leave the gut. So I use BPC 157 in like coaching people for their gut health, but I don't know if that's, going systemic. Do you know, Tanner, have you seen anything?
Yeah, so I get a lot of anecdotes. I mean, most of my followers are just little lab rats anyway.
Yeah.
And so the main thing that I've noticed is that if guys are going to be trying to do site injections, it seems to be almost a little bit more of a detriment, because these are people who are amateurs at home taking needles and just like taking jabs at their ankles or at their wrists or whatever.
Necks or whatever. Yeah.
And at the end of the day, what you might end up doing is just like creating a lot more damage that the BPC then has to heal anyway, along with whatever else is going on in there. And just like what you were saying, if you do a sub-Q injection, you have any idea of like how it's going to be translated throughout your body, it's going to move around, and it doesn't exactly need to be in that specific spot. If you are a little superstitious, maybe you could find a sub-Q spot a little closer to the injury. But again, you're in the world of superstition. There's not much of a difference that's actually going to happen there. I have seen the oral version. It seems to be a little bit less effective than the injectable. And that's also subject to the metabolic health and like generally just like what the person's diet is like. And so if they're living a very unhealthy lifestyle, it doesn't seem to translate as well to recovering their injuries, but that also just could be for a variety of other factors. Whereas like I know guys who are very healthy, they live a very streamlined lifestyle, they use the oral version and they get results that are effectively on par with the injectable.
Yeah. And I think the big pictures or the takeaway here is this is all anecdotal. And so it's things that we've kind of tried, and my thinking as of now, until I'm proven wrong, is that like if you're taking oral, it's probably best for gut health. I mean, I think that it has a lot of utility there. It's synthesized in the gut naturally, endogenously, and so I think that it can help a lot when people have issues with that. Gut health is a whole other tricky subject. But if you're having issues, maybe try C157. If you have an injury, you can inject. And I'm totally with you there. I say like, if it's some placebo that makes you feel better about getting it closer. And I mean, I honestly would probably fall into that too. If I had a knee strain, I would probably inject it in my vastus medialis or something, just because it'd be like, it's a little closer. Why not? Maybe a few more of that will, and I don't know, but it's more probably superstition. I'm sure that if we had some clinical trials and they did like a randomized control versus like abdominal versus side injection, it would probably be pretty similar. Yeah. But like if you were using it with a clinician, like this is what I always thought would be cool, is that I would feel comfortable injecting because I really understand like lower extremity anatomy really well. I have no issue injecting tendons. I do it all the time with steroids and things. If somebody had like a perineal tendon tear, I would feel totally confident injecting straight into the tear in the clinic. And that would be super cool. I don't recommend anybody do that though. And unfortunately, providers just can't get that.
Sure. Yeah, no, that makes sense. I wanted to make this one more comment on testing, because I had an interesting experience. I've done my blood work for years, and the quickest version of it, I guess, was I noticed my iron and ferritin was elevated pretty high, and going through and trying to see what was going on, I very little, like just looking into it, I noticed I was using an iron skillet for like 4 meals a day. So I'm like, all right, like, is that elevating it? Well, my general practitioner was like, we don't have a history of like a hemochromatosis, whatever, like, but if it is genetics, someone at some time had to have it, right? He's like, so let's test you. And I'm like, sure. So short of the long, because, Mike was on me he's like, let's get your blood work through. Let's get your blood work. I was all right, fine. I did it. So when I did it, it popped up high. Long story short, I found out I have one of the 2 gene mutations for hemochromatosis, which I found interesting. My primary, I still need to unpack it further because my primary care said it did lower down. When I stopped with the iron skillets things, I don't know if, how much that translates, how much truth is that. I didn't really research it. I just stopped it because it was just easy. And anyways, finding that out, it was just interesting to see that I had the one. So it's still like at the top end of the ranges, but not like, more in the middle of where it was a couple of years back, which I found that pretty interesting. Is that, I guess first, is there any truth to some of the iron intake that could affect that? As well as, have you heard that where someone maybe has one of the two mutations? I just started learning about it recently. So
Yeah. So when it comes to iron intake, that's, definitely 100% will cause it. Now, that was the first thing I always ask every guy: do you cook on a cast iron skillet or do you cook on like an iron grill? And then another thing that we don't think about is fortified cereals and breads and things like that. And so this happened to me. I have years of labs, and mine have always been normal iron. And then my last one, I think, or maybe two ago now, my iron was like high, like it was throwing an alert on LabCorp's thing saying your iron's out of control high. And I'm like, what the hell am I like doing to cause that? It's really weird because I haven't historically. So I know it's not hemochromatosis. And I looked at the cereal that I was eating, which are these grape nut flakes. And you guys don't make fun of me. I know it's like an old person cereal, but has a lot of fiber. I like the taste of it. But the iron is like something like 300% of a daily value. And I'm a decently big guy. And so I have like probably 3 servings. So I'm having like 900% of a daily value of iron. I'm like, holy shit, that's what was causing it. And so I see that a lot too, like cereals, a lot of our like grains and things are fortified here with iron. So be mindful of that. And it can certainly cause it. And then the hemochromatosis thing is interesting. I forget which one, if you need both or which one of them. So I'd have to look too. And I don't know everything. I'd probably, Google it if I was seeing you as a patient.
sure.
But I can't remember, but yeah, there is 2, and you can be heterozygous. But another thing to think about if you're not, because some people do have like, say, elevated ferritin without an elevated iron gets me concerned for inflammation because it's an inflammation marker. And so that's why ferritin is important for like bodybuilders, things to order as well. I think like Vigorous Steve's probably talked about this for years, measuring not only CRP, but also your ferritin. Because if your iron's normal and your ferritin's high, ferritin should be an iron carrying protein. But it's why is it high? There's not high levels of iron. It's probably more of an inflammatory response. So that's why it's important to look at.
Yeah, no, it was interesting. I mean, they said there was no need because for any medical intervention based on where it was after. But I will say, I used to take like 5 of my protein meals at once. I would cook in a giant iron skillet and just break it out into stuff because it was convenient. It wasn't anything to do with it. And I'm like, I've been doing that for the last 2 or 3 years, almost every day. And they're like, wait, like every day? I'm like every day. I'm a dude. And I don't think I load it with chicken or load it with beef or whatever. I'm like,
those contain iron too, because those are, creatures of blood in them that have iron. So especially red meat,
So
I've been concerned because I've been recently cooking a lot on the grill, which is an iron grill. And I'm like, oh, I'm sure my iron's getting high as hell. Like I probably might need to go give a donation.
Right.
Yeah. So that's one way that you can lower iron. And for some people, it's beneficial. If you do have high levels of iron, give a donation. I don't fall into the anti-donation camp. People are so dogmatic in everything. Just one last little aside, like, even with TRT now, we have so much dogma. It's crazy. For years, it was like 1 injection a week, and then you get an anastrozole and HCG, and it was this cookie cutter. And now we have all these other clinics who say, oh, we're not cookie cutter, but they are cookie cutter. They're just a different cookie where everybody gets 3 injections a week. Nobody gets an AI ever. You can't even bring that up. I mean, there's like YouTube channels who are so anti-AI that it's crazy. And I'm like, okay, I totally agree that not everybody needs one prophylactically. That's absurd. But occasionally somebody may need to lower estrogen a little bit, especially if they're getting things too high. And then same goes with blood donations, where they're literally telling people that doesn't matter how high your hematocrit gets, you never need to give a blood donation because it's not the same as polycythemia vera, and it's never been proven to actually cause strokes. Well, it's also never been proven to not. So let's just be careful. And potentially, if you've got a 56 hematocrit, maybe go give a donation. That would be my recommendation.
Yeah. No,
Yeah.
makes sense.
So it's just like everything, you know, it's like the dogma in everybody. It's like, it's funny that it's in this field now. I'm like, really? So you see people arguing over AI use, and I'm just like, wow, that's funny. It's crazy.
It followed you from fitness into the medical field now. So
Yeah, exactly. Yeah, there's fitness and nutrition and politics, everything. You know, everybody's got to be so dogmatic.
well, good for you though, because you know, you're not only are you servicing patients all day, but I know there's a lot of conferences you're at. We talked about, you know, the Silverback Summit, Swiss. I'm sure there's many more. You're on podcasts, you know, so you know, it seems like you're having fun with it. So
Yeah, for sure.
keep up the
It's an
good
awesome
work.
community. Thanks, man. Yeah, everybody's fun. You know, it's a great community. I'm happy to be here.
Yeah. Tanner, any closing thoughts or questions from you?
No, I'll just piggyback on that. I mean, I've also recently joined the whole little fitness internet world, and I feel the exact same way. People are surprisingly welcoming, and they're all kind of the same off camera as they are on camera. Super, super reassuring, because I mean, especially among my generation, a lot of the influencers are very much a personality on camera and a bit different in person. There's a lot of drama, a lot of gossip, but it's reassuring. It's nice to be around some of the old heads sometimes.
Yeah. Man, am I considered old now? It's so crazy. I feel like I kind of am. It's weird.
Yeah.
Usually Justin takes the cake because he's a couple years older than me, but this time I get to be the old man on the show today.
Nice.
So
Okay,
all right, well,
good.
hey,
yeah, we kind of like staggered here in age.
Yeah, that's fair.
well, thanks again for joining us, Dr. Hotchkiss and Tanner. Appreciate you jumping on as always, adding some value to the content today for everybody out there. You know, obviously we have 1D Talks on our YouTube channel, but you can also find us on all of our audio platforms. And in our show notes too, we'll have where you can find Tanner, and then I've Dr. Hotchkiss as well. So a lot of different resources through his social media, his Instagram, website. Any kind of verbal plugs for the audio folks out there that maybe are driving, where they can find you, Dr. Hotchkiss?
Yeah, I mean, I'm really trying to push the YouTube content now, which is a lot of fun, but also a lot of work. So,
Sure.
and like something like Instagram's so easy to grow, not easy, but like YouTube, man, it's fucking hard. So, like, go over my YouTube, which is Atlas Optimization. If you search that, or you know, search my name, the podcast Atlas Hour, and like I said, I'm putting out other just educational content too. Instagram is Dr. AE Hotchkiss. You'll see it in the description. So yeah, I try to interact with everybody who does reach out. Like I said, if you are going to say something stupid that you haven't done your literature and you're asking me if this trend is good, I may not reply. There's probably a little bit of legal risk there for me too. But for the vast majority, I really love all the dudes who reach out to me. Everybody's super cool. So please reach out. And Instagram, for whatever reason, hides messages forever, and it might take me 3 weeks before I see it, but I do appreciate all of the connecting that everyone does with me.
Yeah, I know. And for all the, I know we put it up in our stories, for all of the Justin Harris fan club that follow this channel. So he was on Dr. Hotchkiss' podcast as well. So it's a really good episode.
Yeah.
If you guys want to check that out, they definitely unpack a lot of great information on there. So
that one did surprisingly well, and like weeks later too. That was one of those ones where it just was like suddenly blew up. Like people talk about on YouTube, 3 months later a video blows up. That's what that one did. People really liked that one. I think it's because we talked about Jason Blaha. Let's do it again. Let's blow this one up. We said like 5 seconds of the guy's name, which I forgot he was even a person. And then all these other channels were saying that we were talking bad about him and like making drama. And I was like, wait, what? And then like Jason Blaha reached out to me. I was like, this is fucking crazy. But hey, that's what you got to get dramatic to get the views, I guess.
Well, we might have to put that in the search terms for this just to get the SEO value. So maybe
we should just title this.
Yeah, there you go.
Like Blaha sucks or something. Like dismantling Blaha.
Well, good stuff. Thanks so much, guys, and thanks everybody for tuning in. We'll see you. Have a good one.